All right, good morning, everybody. My name is Anna Green. I will be presenting on improving outcomes in no man's land, focusing on the recent advances in the treatment of acute zone 2 flexor tendon injuries. Outcomes of primary flexor tendon repairs in zone 2 were very unpredictable for a long time, but over the past couple decades, there have been several surgical techniques that have been established as critical to a successful tendon repair. The goal of the talk today is just to review these developments in repair technique and rehabilitation of acute injuries that are essential to improving outcomes in what has been historically known as no man's land. So let's just start off with a clinical picture to set the scene. This is a 29-year-old female who presented to the emergency department immediately after cutting her right hand index finger while trying to cook dinner. She reports pain in only the affected digit, and she's unable to flex her index digit and has some numbness on one side. She denies any other injuries. X-rays performed in the emergency department were unremarkable, with no fractures or dislocations, nor foreign bodies. On examination of her index finger, there is a 1.5 centimeter linear and oblique laceration approximately over P1. It appears clean. Her digit is held in extension. Sensation is diminished over the ulnar aspect of that finger. She's unable to actively flex the digit at the PIP and DIP joints on isolation. However, the finger is warm and well perfused with brisk cap refill. So her diagnosis, no surprise, she has a zone 2 flexor tendon injury, or what has been traditionally known as no man's land. So how are we going to manage this patient right now? When do we want to fix it? What are we fixing? How are we going to fix it? And how are we going to rehab this patient afterwards? So these are some of the questions that I hope to discuss today. Just quickly, if there's any juniors in the audience, what do you want to do to this person right now? Just some basics. You just have an open laceration of the fingertip or the finger. Wash it out, good. Tetanus, antibiotics, good. So just to rewind and give some background, flexor tendon injuries have an incidence of approximately 4.83 per 100,000 persons per year. Approximately a quarter of these injuries are work-related and a quarter have concomitant nerve injury. Managing these traumas have been challenging ever since they were first described. Although much progress has been made in our understanding and treatment of flexor tendon injuries, they still remain amongst the most difficult orthopedic conditions to manage. Up until about the 1960s, it was universally recommended that tendons lacerated within the digit, then referred to as no man's land, should not be repaired. At the time, Dr. Bunnell taught that, quote, it is better to remove the tendons entirely from the finger and graft in new tendons smooth throughout its length. This was the norm until reports by Verdun, Kleiner, and Kessler challenged this concept that flexor tendons should not be repaired primarily, and showed that immediate tendon suture would outperform secondary free tendon grafting like Dr. Bunnell had originally suggested. Life pro tip, do not do this at home. So it's important to understand the anatomy of the flexor tendons in order to properly diagnose and manage these conditions. The FDS, FDP, and FPL are the major tendons that supply the hand. The FPL is a deep flexor that originates from the mid-radius and interosseous membrane and is innervated by the AIN branch of the median nerve. It traverses the carpal tunnel radially en route to its insertion at the base of the distal phalanx of the thumb. The thumb has an additional flexor muscle, the FDP, which is intrinsic to the thumb. FDP muscle originates from the proximal 3/4 of the ulna and interosseous membrane and has dual innervation from the AIN, which supplies the index and middle fingers, and the ulnar nerve, which supplies the ring and small fingers. The FDP inserts into the base of the distal phalanx and acts as a primary flexor of the DIP joint. The middle, ring, and little fingers share a common FDP muscle belly. The FDS muscle originates from the medial epicondyle of the distal humerus and the proximal radius. It is innervated by the median nerve, which lies deep to its surface. These tendons travel from the forearm through the wrist and into the hand via the carpal tunnel. In the carpal tunnel, the FDP tendons lay deep and side by side, whereas the FDS tendons are arranged in 2 layers. The middle and ring fingers are volar, and the index and fingers deep to that. Each FDS tendon divides at the MCP joint into radial and ulnar slips, which permit the FDP to pass up through the FDS. These slips rotate 180 degrees and then reunite beneath the FDP at Camper's chiasm before they redivide and insert on the middle, about 3/5 of the middle phalanx. The tendon pairs to each finger lie encased within a tendon sheath distal to the MCP joints, which isolates them from the surrounding tissues. The tendon sheath is comprised of two membranes, an outer parietal layer and an inner synovial layer coating the tendon, which are in continuity with each other at the proximal and distal ends. The virtual space between the two membranes is filled with synovial fluid, which is lubricating the tendon, allows gliding, and contributes to tendon nutrition. Thickenings in the fibrous sheath result in 5 annular pulleys, noted A1 to 5, and 3 cruciate pulleys, C1 to 3. A1, 3, and 5 pulleys originate from the volar plates of the MCP, PIP, and DIP joints, respectively. Of note, the thumb has a unique pulley configuration, including 2 annular pulleys, A1 and 2, and an extension of the adductor pollicis aponeurosis, forming a single oblique pulley overlying the proximal phalanx, which is considered the most important. The digital pulley system provides a series of fulcrums ensuring tendons remain adjacent to the axis of the phalanges. This facilitates conversion of linear translation to rotational torque at the IP joints. Historically, the A2 and 4 pulleys are considered critical to the prevention of bowstringing and subsequent loss of functional excursion, but we'll talk about this a little bit later. Tendon nutrition is also important when considering these injuries, and this comes from both vascular and synovial sources. Synovial fluid diffusion is accomplished by a pumping mechanism known as imbibition, in which fluid is forced into the interstices of the tendon as the digit is flexed and extended. And vascular perfusion of the flexor tendons is additionally provided by longitudinal vessels that enter in the palm and extend down the intertendinous channels, vessels that enter at the level of the proximal synovial fold in the palm, segmental branches from the paired digital arteries that enter in the tendon sheaths via the vincula, and vessels that enter the FDP and FDS tendons at their bony insertions. The pulley system plays a vital role in the biomechanics of finger motion. Simply stated, the greater the distance a tendon is from the axis of joint rotation, the greater the moment arm and the less motion that a given muscle contraction will generate at that joint. Conversely, a shorter moment arm will result in more joint motion from the same tendon excursion. The pulley system functions to reduce this moment arm length, allowing better motion at the joints. The A2 and A4 pulleys are the most biomechanically important. The loss of a substantial portion of either may diminish digital motion. This becomes important later when we'll discuss resecting some of these pulleys to improve tendon gliding after repair. An improved understanding of the basic biology behind the flexor tendons has also helped us improve management of these conditions. Tendons are primarily composed of tropocollagen, which consists of 3 peptide chains arranged in a triple helix. Groups of these tropocollagen molecules form microfibrils, which then aggregate to form fibrils and then fibers. Tendon fascicles consist of tenocytes, and then these collagen fibers. In the hand, the flexor tendon fascicles are then covered by a thin visceral and parietal adventitia called the peritoneum that is associated with a fluid environment, so similar to synovial fluid, like I mentioned before. So the science behind tendon healing has been a target for recent research in optimizing flexor tendon outcomes. Tendon healing occurs primarily in 2 pathways called the intrinsic and extrinsic. The intrinsic healing is produced by the tenocytes within the tendon, and extrinsic healing is stimulated by the surrounding synovial fluid and inflammatory cells. The extrinsic pathway is implicated in the formation of scarring and adhesions, so it's a pretty hot topic and target of research. Healing is divided into 3 separate phases: the inflammatory, proliferative, or fibroblastic, and remodeling. The inflammatory phase lasts about 48 to 72 hours from the initial injury. During this phase, the strength of the tendon is really just equivalent to the strength of the suture repair. The proliferative phase starts on the 5th day and ends around the 4th week. In this phase, the tendon repair strength increases exponentially because of the newly laid collagen. The tenocytes lay down a temporary matrix consisting of mostly type 3 collagen with 4 mechanical properties And then the strength of the repair, it just increases compared to that of the initial inflammatory phase. The remodeling phase continues until approximately 3 to 4 months after. During this phase, type 1 collagen synthesis begins and the extracellular matrix aligns in response to mechanical stresses. The repair tendon achieves its full post-repair strength at this time. However, it usually does not regain its full pre-injury strength. Flexor tendon injuries are typically described by the Verdun classification, which describes them from distal to proximal. You have zone 1, which is typically called the Jersey finger, which goes from the FDP to the FDS insertion. Zone 2, which is today's topic, goes from FDS insertion to A1. Zone 3 goes from proximal A1 pulley to the distal carpal tunnel. Zone 4 is within the carpal tunnel, and zone 5 is proximal carpal tunnel to the musculotendinous junction in the forearm. Zone 2 can also be broken down into these subdivisions, where zone 2A is under the A4 pulley, zone 2B is under the C1 pulley, zone 2C under the A2 pulley, and zone 2D under the A1 pulley. As you can also see in the lower left diagram, this becomes a little bit important when talking about some outcomes in terms of specifically within the zone 2 area. So briefly on evaluation of these injuries, the diagnosis of flexor tendon injury is almost entirely clinical. You shouldn't need any advanced imaging. There should always be a careful inspection of the neurovascular status to ensure a properly perfused digit by considering skin color, temperature, turgor, and cap refill time. Neurostatus can also be assessed using light touch and 2-point discrimination. Observing disruption of the cascade, arresting extended finger, and loss of normal tenodesis indicate flexor tendon injury. You have to isolate the testing of the FDS and FDB tendons, which is important, which you can see in the far right upper and lower images, in order to determine whether or not the FDP and FDS tendons are lacerated. It's also important to note that the level of the skin laceration may not directly correlate with the level of the tendon retraction based off of the hand position. So overall, the general goals of these flexor tendon repairs are just a strong and stable repair with minimal gapping and a smooth repair interface. And you want to avoid adhesions, contractures, and re-rupture. So before we talk about how we've improved these outcomes, I wanted to touch a little bit on how we're assessing and measuring these outcomes. There are several evaluation systems. The total active motion, which was created initially by the ASSH, takes the sum of the active ranges of motion from the MCP joints to the DIP joints, and then compares it to the contralateral uninjured hand. And then the percentages then fall within the excellent, good, fair, and poor categories. Strickland's criteria is also commonly used, and this just includes the PIP joint and the DIP joint, leaves out the MCP joint. Buck-Gramco, which is I think a little bit less common, it just added a very good category, so it increased the number of subdivisions. And then more recently, Jinbo Tang, who you'll hear a lot during my talk, created a grading system which wanted to be more stringent than the other systems. So if you look at the percent return of motion, he wanted excellent to be 90 to 100, whereas the Strickland criteria, both original and revised, was 75 or 85% compared to the uninjured hand. Overall, you can see that these outcome measures don't really correlate well. So when you're reading literature, it's important to look at specifically which grading system that they're using, because in an extreme case, you can take someone who's poor in one scale and then they'll be excellent in the other scale. So now we'll go through some of the literature on the surgical aspects of improving flexor tendon repairs. When are we going to fix it? How? And what are we going to do after? I think timing is important. When are we going to fix it? Overall, there's a lack of strong literature to support an optimal time for surgery. On a survey of US hand surgeons in 2017, 33% of surgeons said that they do a primary repair within 3 weeks, and then 43% said within 4 weeks. Most surgeons just advocate fixing them as soon as possible. This is an interesting study from Finland in 2019 that was originally published in the Journal of Hand Surgery, the European edition. This looked at the effect of delay to surgery on major complications after flexor tendon repair. They looked at 187 tendons, the majority of which were zone 2 injuries that were repaired either the next day or then recorded when they were referred and repaired, ranging from 0 to 24 days. They were reported with 3/0 or 4/0 polyester Kessler sutures with an epitendinous suture. And they found that there were increased complications, namely adhesions and re-rupture, when the repair was between 3 to 7 days. This led them to advocate that you should either repair it just immediately within 24 hours or at least waiting a week, just because of the higher risk of complications. However, repair may be more difficult the longer you wait, so they really just stress that you should just do these as soon as possible. I don't know if there's any hand surgeons on, but I don't, what are your thoughts in terms of the timing? Do you repair them like immediately? Do you wait a couple days?
Well, I don't know who else is on or not, but Tim Letty here. I repair them as soon as I can. You know, unfortunately, it ends up dealing more with, you know, the scheduling of things and how quickly I can get an operating room. And, you know, if it ends up looking like it's going to be too far down the line before I'm going to have a scheduled day in the office, then I'll make a day. Like I'll just pick a morning and have it done, because I don't like to do them delayed. I think you're into that zone of time where the tendon is already degenerating. You put sutures in that and they don't always hold. So I like to get in there, you know, early. I don't have a problem with missing the very first couple of days, that early inflammatory phase. But when you start to get tendon breakdown, that's a problem for me. So I'm going to be on the earlier side.
I would agree with Tim. I think as soon as you can get to it, because you don't want to run into a situation where you have trouble getting it back in it. And then you have to start thinking about other things. And nobody, well, not nobody, but most people wait. They see you a few days or a week later. Sometimes, you know, they're worried about getting certification, authorization, and Tim's right. So I think, you know, as soon as you can do it is the best option, because too many times people come in late and then you're in a reconstructive phase.
So if someone comes into your office acutely, like within the first 24 hours, 48 hours, would you ever send anybody into the emergency department to fix them, or would you just schedule them electively?
No, that, you know, whether you do it in the first few days or first 7 to 10 days doesn't make, you know, I think you just don't want to wait 3 weeks, 4 weeks. But by that time, problems start to occur and it becomes more difficult. So there's no rush. This is not an urgent matter. You don't have to admit them that day and do it. But whoever sees the patient, whether it's the ER, the resident, just should let the doctor know. So the office doesn't say, come in 2 weeks and we'll check the wound.
All right, thank you. So moving on, we'll start with just their basic approach to fixing the flexor tendons. A Brunner incision, or less commonly a mid-lateral approach, is typically used for exposure of the tendons. There are a variety of methods involved to retrieve the tendons that may have retracted within the sheath, including the milking maneuver, catheter retrieval, where you essentially just funnel a little catheter down, tie it, and then pull it back through. Reverse S-mark, which I haven't seen used, but it sounds like in the literature, some people report good outcomes using that, just to sort of, instead of starting distally, start proximally, and it's almost like the milking maneuver. And then the use of a tendon passer tool is critical. Lacerated tendons in zone 2 can retract proximally to the PIP when the vinculum longus remains intact, or into the palm when it is disrupted. The lacerated FDP tendon will usually not retract to the level of the wrist because of the origin of the lumbrical from its radial surface and its insertion distally into the extensor mechanism. If the FDP stump retracts into the palm, many surgeons advocate, instead of extending the incision all the way to the palm, to just create a small window, which can be used to locate the tendon and then channel it distally using 2 forceps. Once the tendon is grasped, it is often easily tacked down with a small 25 gauge needle to prevent re-retraction during the repair. But most important, it's just, and you have to think about being really careful and gentle with all of the tissues, the tendon, and everything surrounding the incision, because aggressive and unnecessary damage to the tendon sheath or the tissues increases the risk of adhesion and contracture and can decrease your outcomes. So what are we repairing? Do we repair the FDS, both slips, just the FDP, one slip? Ideally, I think you repair everything. You repair both slips of the FDS and FDP tendon, as this is shown to just best recover your full strength and dexterity. Sadek showed this in his case series in 2020. However, repairing everything can lead to a large, bulky repair site that may not glide through the sheath easily and can increase your risk of adhesions and contractures. Paillard's group out of the Mayo in 2002 showed that there was a decreased resistance to gliding of both FDS and FDP. And when one of the FDS slips was resected in the cadaver studies, this decreased your work to flexion. And then similarly, Huang in 2009 showed decreased work of flexion with one slip of the FDS resected. So some hand surgeons even advocate resection of both slips of the FDS. Jinbo Tang, who I mentioned earlier, is one of the leading hand surgeons who publishes a lot on flexor tendon repairs out of China. He advocates for abandoning the FDS entirely, particularly when it's in zone 2C, which is under the A2 pulley. Given his experience, this is a really narrow area in the sheath and has a higher risk of adhesion formation, so he just doesn't risk it. So I think it's dealer's choice. I think a lot of it just depends on what you're dealing with when you go in. And then once you repair the FDP, what is the gliding like? And then you can go from there. The principles of strong flexor tendon repair have evolved exponentially since the 1960s, when the paradigm shifted from advocating to primary repair. These are some of the major concepts derived from recent research, some of which we will expand on shortly. The strength of the repair is proportional to the number of core sutures. The caliber is correlated with the strength of the repair. The core suture purchase should be approximately 7 to 10 millimeters from the tendon edges. There should be proper tensioning. Locking is usually stronger than grasping loops. The location of the knots, the dorsal location of the core sutures, and then also the type of suture material that you use. But overall, no matter what you do, it's really just important to test intraoperatively your digital flexion and extension to gauge what may be needed to be done at the time in order to allow proper tendon gliding. So tendon repairs typically involve the use of core sutures with a circumferential epitendinous suture. There's a million core suture configurations, some of which are depicted here. 2, 4, 6, and 8 core suture configurations have been described. Biomechanical studies of these multi-strand techniques demonstrate increased gap formation with the 2-strand repair formation and increased tensile strength with the 6-strand repair formation. Although 2-strand core suture repair is technically the easiest to apply, it's really not strong enough to withstand the forces generated in early active motion rehab, so it's largely been abandoned. One of the most studied and simplest and frequently used core suture patterns is the modified Kessler. So how many core strands do we need? We know based off of multiple biomechanical studies that the strength of the repair is directly related to the number of strands crossing the repair. So 6 is stronger than 4, which is stronger than 2. But more is not always better. More suture strands that cross the repair site means the more likely the method is to damage the tendon excessively or compromise its nutrition or ability to heal. It also leads to a bulkier repair. The International Federation of Societies for Surgery of the Hand Committee reported that there's a trend for later ruptures with these larger multi-strand repairs, mostly the 8-strand repair. Early ruptures were observed in the 2-strand groups just due to suture failure, whereas these multi-strand repairs failed a little bit later, and they attributed that to potentially disruption of the tendon healing. Additionally, these core sutures should be placed between 7 and 10 millimeters from the tendon edges, which was shown by Tang in 2005. And then dorsal placement has also been shown to be biomechanically stronger, which was shown by Sojima in 1995. So what size suture should we be using? Technically, bigger is better based on biomechanical studies. Taras in 2001 showed using cadavers that with each increasing suture size, there was at least a 50% increase in the strength of the repair. Another study by Hatanaka and Mansky in 2000 showed that 3.0 and 4.0 sutures were equivalent to 2.0 sutures if a locking suture configuration was used. Other studies have similarly shown that locking configurations are overall stronger, which minimizes sliding of the suture material through the tendon. However, when you increase the size, you decrease the number of core strands you can securely fit in the tendon. In 2014, Osei et al. Investigated suture size and core strand number in cadavers and found that although increasing the size of the suture increased the strength, the overall effect of increasing the number and core strands was greater than increasing the size. And so he recommended that we prioritize using a smaller suture with a greater number of core strands crossing the repair site, with the most common sizes being 3/0 and 4/0. So if you look at his data from his study, you'll see that even though he used the smaller strands, if you go from using a 4-strand to 8-strand repair, that nearly doubled, whereas if you just go up one, that only goes up a little bit in the maximal load to failure. There's a variety of suture materials that hand surgeons use in tendon repairs. Overall, you want a suture that it has high tensile strength, that is inextensible, is inert to the tissues, and is easy to handle. For example, stainless steel is really strong, but has poor handling characteristics, problems with kinking and bulky knot formation, so it's fallen out of favor more recently. Another common material nowadays is Supermid, which is a synthetic polyfilament and sheath in caprolactam, which I know that Dr. Jinbo Tang uses a lot in his studies. This is a study from 2005 by Lawrence and Davis, who compared these different suture materials in a porcine model. He concluded that fiber wire and stainless steel were the strongest in terms of gap force, or the force required before he noticed gapping, and ultimate force, which was the force required to rupture the repair. So he recommended using fiber wire, especially since stainless steel was harder to handle. But I know a lot of people still use Ethibond. A newer crucial concept that has developed in the past decade is the proper tensioning of these repairs as well. We often talk about tension-free repairs, which is crucial for nerve and vessel repairs, but this does not apply to tendons. This study by Drs. Wu and Tang in 2012, which was published in the Journal of Hand Surgery, looked at tensioned repairs in 57 porcine flexor tendons, which were repaired with 2 different suture configurations, and they varied the amount of tension in the repairs. The repairs were either tensionless, they produced 1 millimeter or 2 millimeters of shortening on either side of the repair, equaling approximately 10 and 20% of shortening. They then applied tension across each of these repairs and measured the load to failure, as well as the 2 millimeter gap force, which is the force required before you saw gapping. They found that these pre-tension repairs, at least 10 to 20% shortened, were significantly stronger and reduced gapping formation. So similarly, there's a study by Giesen, which I'll mention later as well, in Europe, who noted that repair site bulkiness up to 150% of the normal tendon did not impede gliding, which is another concern when you're pre-tensioning these repairs. He noted that there was a large range of bulkiness that was allowed, which provides surgeons the opportunity to tension the repair to resist gapping, but you need to test it intraoperatively to determine what that safe range is. There is some variation in knot location as well amongst hand surgeons. Knots are the weakest component of a construct with ruptures occurring often at the knot location. Knots within the repair site are either internal or externally placed on the surface of the tendon. Intratendinous knots may reduce friction, but may predispose the repair to gapping, since the knot is interfering with the tendon-to-tendon contact. Several studies have shown that internal knots have decreased strength compared with external knots at day 0. However, by 6 weeks after the repair, there was no difference in tensile strength between internal and external knots. So I think this might be something that's dealer's choice for the time being. Core sutures are often bolstered by an epitendinous suture, which is often just a simple running or horizontal locking with a small 6/0 monofilament suture such as nylon. Studies have shown that the epitendinous repair adds strength to repair, but most importantly decreases gapping. So there's a systematic review by D et al. In 2012 that found that simply adding an epitendinous suture decreased the rate of reoperation by 84%. Interestingly, there have been more recent reports that have challenged the need for this epitendinous suture, saying that it may be superfluous when a strong core suture repair is done. And this was also mentioned by the Giesen in 2018. As I mentioned before, it was previously believed that the A2 and A4 pulleys were sacrosanct and should not be interrupted, as this would cause bowstringing and disrupt the efficient biomechanics of the flexor system. Most hand surgeons now agree that the critical annular pulleys can and should be vented during the primary repair to allow a freer tendon gliding. Although it was not acceptable 20 years ago, this practice is now considered critical to ensure functional recovery and is unlikely to cause clinical problems when executed cautiously. Tang advocates judicious venting, though he recommended that this should never be more than a total of 2 centimeters of the total pulley system. He reports venting up to 2/3 of the A2 pulley and even all of the A4 pulley, and has had good results in his patients. Giesen in Europe reports similar results in venting pulleys, where he showed, as depicted in the figures, that A2 is probably more important than A4 in terms of limiting bowstringing, and A4 can be entirely vented with less impact on finger dynamics than A2 venting. So this was his study in 2018 by Giesen, who described his outcomes of 32 zone 2 flexor tendon repairs done with resected parts of the pulley system, including A3 and A4 completely divided, partial A2 and 4, and then a complete A2 as well. He actually found that in follow-up, there was no clinical bowstringing in any of his patients. They resected part or all of FDS if they found that the repairs were too bulky. This was an intraoperative decision taken case by case. And they did not find significantly reduced strength in these patients. Again, this is a really small sample size, and this is just a one surgeon's experience. But I think it's just some support that shows that tendon gliding is probably more important than preserving what was traditionally known as these critical pulleys. Another study that supported judicious pulley venting is by this group from China, Zhang Junpan, who is considered a leader in flexor tendons. In addition to Jinpo Tang in China, in 2019 reported no re-ruptures and 87% good to excellent outcomes when they looked at 60 digits with zone 2 injuries with an only FDP repair. A4 was completely vented in 14 patients, and 2/3 of A2 was vented in 40 patients. They all underwent an early active motion rehab protocol. And the majority of patients, 87% had good to excellent Tang outcomes, and the other 23% who did not score based off of the Tang system only had a mean deficit of 18 degrees extension. So they concluded that pulleys should be vented as needed. Another concept that has, emerged for use in flexor tendon repairs is wide awake surgery. Under wide awake settings, as advocated by Higgins and Lalonde, Wallant allows active digital extension and flexion, which is a powerful validation of the quality of repair intraoperatively. This involves asking the patient in the operating room after the repair to actively flex and extend his or her finger to observe free tendon gliding and observe for any gapping at the repair site. If there's any gapping, you can strengthen the repair with additional core or peripheral sutures. And any pulleys that you note to be inhibiting smooth gliding can be judiciously vented. This was Lalonde's retrospective review of 122 tendon repairs performed using wide awake local anesthesia, no tourniquet, with minimum of 3-month follow-up. Rehab programs were variable throughout the study, though he notes that they transitioned to early active towards the end of their study. They overall reported only 3.3% of tendons rupturing, which were all accidental occurrences such as falling during the early perioperative period or trying to catch something that was falling. They endorsed using wide awake surgery as a method of intraoperative assessment, a confidence boost for surgeons to begin active motion early, and a way to get to know their patients while they're awake and to figure out their compliance levels, to figure out maybe a better rehab protocol that would suit for them. Though I'm not sure talking to a patient during surgery may always be a good thing. Of almost equal importance to optimizing outcomes as the repair itself is the post-operative rehabilitation of these injuries. Flexor tendon rehab has been studied extensively, and advances have revolutionized treatment by decreasing rupture rates. Factors that influence the outcome of flexor tendon repair include age, mechanism, comorbidities, level of the tendon injury, access to therapy, and patient compliance within the postoperative period. Rehab protocols incorporate varied proportions of active and passive motion, and each protocol has some inherent complications. Passive protocols are associated with complications such as poor gliding between the FVP and FDS, resulting in adhesions, flexion contractures, and decreased range of motion. Active protocols, however, are associated with a higher risk of rupture than passive protocols. However, with the advances in suture material and strength and surgical techniques, rupture rates have decreased. Current protocols are designed to improve results by increasing tendon excursion, and this includes the Kleinert, modified Duran, and early active programs. In brief, in terms of the controlled passive protocols, the Kleinert protocol involves attaching rubber bands to the patient's fingers. The patient actively extends the fingers within the confines of the orthosis, and then these elastic bands passively flex the fingers back down to the palm. The Duran protocol involves full passive flexion of the fingers, followed by active extension within a dorsal blocking splint. And then and a protocol which has emerged more recently is the early active motion protocol. And this often consists of place and hold flexion, and then active extension within a dorsal blocking splint and tenodesis exercises of the wrist and digits outside of the splint, which begins 2 to 5 days post-operatively. They then begin controlled limited active flexion of the affected digit. Jinbo Tang stresses avoiding extreme digital active flexion because the tendon has increased resistance to gliding with higher flexion and is more prone to rupture again when it's being pulled while in the flexion position. So his patients will usually just do a semi or partially flexed active protocol. This was a study by Trumbull et al. In 2010 that was published in JBJS. This was a really good randomized prospective trial comparing early active motion to passive motion therapies. Excuse me. They had 119 digits, which were randomized, and they measured range of motion at 6, 12, 26, and 52 weeks later, as well as final dash scores and dexterity scores. The early active group had significantly greater combined IP range of motion at all time points, as you can see by the bolded values in the table to the right. They also looked at dash scores, which were not different, as well as two different dexterity tests, which are the Jebsen-Taylor and Purdue pegboard. Those are basically just timed tasks. And they also found that smokers and patients with associated nerve injuries had overall worse outcomes. But overall, they found no difference in rupture rates amongst the protocols, which is often a concern when initiating these early active motion. So their major conclusion from this was that you can get better range of motion with these early active motion protocols with no difference in re-rupture, which is the biggest concern with starting people on active motion right off the bat. A growing concept in flexor tendon rehab, as well as the Manchester, is just splinting post-operatively. This was a splint that was discussed a lot last year at the International Hand Society Conference. This is a shorter splint than the typical forearm splint, which allows wrist motion in comparison to the traditional dorsal blocking splint. This was a study by Peck et al. Published in the Journal of Hand Therapy in 2014, which compared traditional splints with the short splint. They measured PIP and DIP range of motion at 6 and 12 weeks, and they found no difference in re-rupture rates. However, they found that the short splint had significantly less flexion contractures, noted by a decreased extension deficit at the proximal interphalangeal joints compared to the traditional splint at 6 and 12 weeks. At final review, the short splint had significantly greater arc of flexion at their DIP joints and a greater proportion of patients with excellent and good Strickland outcomes. Some surgeons, even nowadays, are using early active motion without a splint, but they really just stress the need for finding the reliable patient. Jinbo Tang talks about that a little bit, but he, like I said, it completely depends on your compliance and your patient population. So although rupture rates of primary repairs have decreased substantially, ruptures still remain a persistent complication. Adhesions remain a major complication as well and are more frequent than repair ruptures. And some of these require tenolysis. Typically, this occurs when range of motion is not achieved after about 3 months, at least, of hand therapy. You should wait off for surgery for at least 3 to 6 months following the primary repair to allow for healing and revascularization, so you don't endanger the tendon strength. This is, I mentioned earlier, an article published in the Journal of Hand Surgery in 2017, which was just a survey of ASSH members on their preferences for flexor tendon repairs. I think this would be interesting to kind of go back to and talk with the other hand surgeons on to see how they may disagree or agree with some of these common practices in 2017. You'll see that a lot of people were using fiber wire as well as Ethibond at the time. People were using Kessler's technique. A lot of people were using 4-strand repairs and fewer people with 6-strand repairs. Most people were using epitendinous, flexor sheath repair. Most people weren't doing that. And almost 90% were doing partial resections of the A2 and 4 critical pulleys. And most people were repairing both FDP and FDS. And about half and half in terms of early active versus early passive. Future research is largely focusing on using biologics. I won't really go into these, but I think it's maybe interesting to see what comes of these to reduce adhesion formation. So in summary, Bunnell in 1928 said it's better to remove the tendons entirely from the finger and graft in new tendons smooth throughout its length. And so what happened to get to 80% excellent and good outcomes, lower rupture rates, and